Welcome, Amy.
Hey,
Great. So let's kick off and we will have others join as we go. So welcome, everyone. This is a conversation on point of care ultrasound towards a community of practice. So my name's Leith Greenslade. I'm coordinator of the Every Breath Counts Coalition, and I'm very happy to be moderating this call today. You've all received the agenda by email, but I'm going to pop it in the chat again. So we're going to use, I think, the first maybe half of this call to hear from the IMCI Plus team. It's a big effort, and you're going to hear from 4 of the leading researchers. Then you'll have some time for questions on what they present. But then we really want to do a round robin on this call and come to each of you with relevant ultrasound work, point of care ultrasound work, to get a rapid update on what you're doing. And we'll use that to build a database that will be open to everybody. But more on that later. We ask you to keep your videos off and muted if you're not speaking, but please use the chat. This is a very informal conversation where many of you know each other, many don't. We really want to build relationships. So please do feel free to share comments, questions, anything you would like in the chat. And this is being recorded and will be available widely on YouTube, hopefully later today. So without further ado, let me hand over to our first speaker, Christina Keitel, and she will tell you exactly the many hats she wears, but her question's a provocative one and one we need to get out of the way early. Why are we here? So Christina, over to you.
Thank you very much, Lee. Thank you for joining everybody, and Jack will just kick it off. Why we're here and why we called for this meeting together with Lee. It's just a start, and hence towards a community of practice. You can go next, Jack. Is that work is growing around lung ultrasound research, and we have a keen interest and a responsibility to make it useful. And for that, we have to work together. And why we have to work together and what it is we have to work together on, hopefully we can walk to today. So there's a need for platform trials with aligned protocols for data collection. And more importantly, also that research and protocols have to be contextualized and into clinical care where we work. We specifically work in Africa, so very important to integrate here. Next. So this is, here's a list of the current partners on our platform trial across Africa. As you will see, it's a combined interventional trial and cohort study on lung ultrasound. A lot of the partners will present today. Next. And really, we want to motivate your institution also to join. So as you know, we work in the IMCI context. Here's a busy picture from a health center in Tanzania, where diagnostics for pneumonia are mainly clinical. And there's an interest, next, Doc, to improve management and diagnosis of pneumonia in the IMCI framework, which is currently clinically based. Next, to improve antibiotic prescription for pneumonia. Who received of antibiotics in her short life, which is actually representative on a population in Africa level. So right now we're seeing a big challenge around inappropriate antibiotic prescription. Next. To tackle that, WHO and Yassir's group have called for action to improve management and diagnosis of pneumonia through the integral lung ultrasound. And adding to this framework, on the right, the most current guidelines for the management of pneumonia in children under 10 years of age. So there's also an interest in expanding to age. And there's a lot of gaps around lung ultrasound, which our study aims to close. But again, we can only do this together as a group and collaboratively, and hence we are calling for collaboration today. And with that, I'll hand it over to my colleague, Professor Faye from Senegal, from UCAT University, to explain a bit more around the IMCS trial.
Thank you, Christina. Hello, everybody. Yes, I will talk about the RCT. It is integrated management children illness associated with point of care lung ultrasound. It's a study who will explore the utility and the interest of using lung ultrasound in point of care in IMCI context and on primary care. The study has 3 components. The RCT is one of the components, the randomized control trial. We have observational cohort where we will include children who have generally a criteria of exclusion for the randomized control trial. And we have a third component, which will be the TB sub-study for children with suspicion of tuberculosis. Next. It will be a prospective, open-label, randomized control trial with 2 arms, 1 interventional arm and 1 control arm. Like I said, which will investigate the point of care lung ultrasound for the management of pneumonia in outpatient or patient children coming in emergency room settings. The core primary objective of the study is to concurrently evaluate if the integration of point of care lung ultrasound will allow to reduce antibiotic treatment on day 1 and is non-inferior in terms of clinical failure by day 8 in the follow-up among children aged from 60 days to 12 years with IMCI pneumonia when we compare with children who receive routine care without the point of care lung ultrasound. Diapositive. Our population will include children from 6 days to 12 years with clinical criteria of IMCI pneumonia and who is consulting with sign of IMCI pneumonia. And in the RCT will include those with non-severe and severe pneumonia, and in the observational cohort will include all the other patients. And we aim to have approximately 500 patients and 3,500 in the RCT, 5,000 patients in total. Diapositive. The intervention group will receive, the healthcare provider will receive the PLUS report. This healthcare provider is not a study staff member. It's to integrate PLUS into the current IMCI guideline for pneumonia, and the healthcare provider will receive instruction about antibiotic prescription depending on the result of the lung ultrasound. And all the patients will have PLUS the point of care lung ultrasound on the day 1 of the enrollment by a study clinician in the facility. Diapositive. Diapositive. Yes. Comparing the control and the intervention group in the facility, children will be screened for sign of pneumonia with IMCI criteria. And if they have pneumonia, they will be consented and enrolled. And after that, information will be captured in REDCap, including clinical information, and lung ultrasound will be performed at this stage. And after the lung ultrasound, children will be randomized into control group or in lung ultrasound group. In the control group, no information will be given about the lung ultrasound, and the patient will receive routine care, which include, in our context, administration or prescription of antibiotics. But in the intervention group, the loss report will be given to the healthcare provider, and will allow to categorize the patient in 3 level of risk depending to the result of lung ultrasound: low, intermediate, and high risk. In the low risk, they will not receive antibiotic. In the high risk, they will receive, and in the intermediate risk, the prescription of antibiotic will depend on clinical sign associated. In the intervention group, children will be assessed clinically for danger seen, for severe disease, and classified like in IMCI, classic IMCI. And the clinical information will be crossed with the lung ultrasound results to determine the risk and the use of antibiotics. In case of severe pneumonia and severe disease, children will be advised to receive intravenous antibiotic, and for high risk what I say is that children will be advised to receive intravenous with intermediate and high risk lung ultrasound, but not in low risk lung ultrasound if the case is severe or pneumonia or very severe disease. But for simple pneumonia, only high risk will receive antibiotic orally, and not low and intermediate risk lung ultrasound risk. It's okay.
Great, thank you very much. If it's possible to run my video on Leap, that would be great. If not, that's fine. Hi, everybody. It's wonderful to be here. My name is Jacques Dutoy. I'm a clinician and a researcher based in South Africa, and part of the IMCI Plus Consortium. And just to follow on from what Christina and Prof. Bay have said, I think just to highlight the importance of the context of the study. So the context really is in an IMCI setting. And so I know that many of you on the call, I do recognize, some I don't. And so I think just that contextual piece is quite important. I think lung ultrasound, especially point of care lung ultrasound, is used quite widely and increasingly in kind of high income settings and hospital settings. And there's a lot of work towards kind of diagnosing pneumonia. And I think just to kind of clarify, in our study, it's really about trying to help clinicians and guide them to make decisions around, do I give antibiotics or not, within the context of IMCI pneumonia. And I think just to state again that IMCI pneumonia, as many of you know, is really a clinical entity based purely on kind of some signs and symptoms. And so it's not necessarily trying to make a claim of diagnosing a bacterial pneumonia or a bacterial pneumonia or a viral pneumonia, but more trying to allocate kind of likelihood of those that would benefit from antibiotics or not. And so as many of you who've been involved in lung ultrasound type research would know, I think that there's been a lot of work going into trying to create some levels of standards around courses, etc. And in many of the countries that we're working in within Africa, there really aren't a lot of opportunities for kind of formal accreditation within POCUS, but specifically in lung ultrasound. And so to try and create some form of standard, which we think is really essential to make sure that, you know, when we're all doing a lot of work in this area, to know that we're all kind of singing from the same hymn sheet. We try to create a very clear, standardized way that we could say we could conduct training on how to use lung ultrasound. But because we're using these results for patients, we really want to make sure that the interpretations are being done correctly. And as I said, because in, say, for instance, this setting, many clinicians in this setting have not used ultrasound before. And so how do you very safely and kind of consistently and repeatedly kind of give out a training program? So what we did is we developed a standardized training program, which we called the IMCI Plus training program. And we created 5 different levels, really, of what we call entrusted professional activities, so EPS. So what this involves, basically, is we'll have a level 1 where we would conduct a point-of-care lung ultrasound theory session to give people the basics of how to use ultrasound and how to identify things on images. We then followed up with a practical session, which is what we call level 2, and this is primarily focused at training people to acquire images and videos correctly. And so this was done with 10 kind of directly observed point-of-care lung ultrasounds in person with the trainees. Then we followed with what we called level 3, and level 3 was really around ensuring that now that we can take the images well, and we're not missing things, we're not scanning the abdomen by accident, can we identify the features accurately? And so to do this, and obviously they'd obviously been trained this in level 1 and 2, but here we formally did it where every trainee had to conduct 25 scans, and these were done independently, and the scans were captured and recorded. And then they would need to fill in a form, basically to do an interpretation of all the different views according to the acquisition protocol. And this would be to make sure that they can see all the things that we thought were relevant for this. So things like pathological B-lines, consolidations, bronchograms, pleural effusions, etc. And then these were reviewed by an expert. So we would then review the scans. We'd make sure that they've identified all the severe pathologies, that they weren't saying a stomach is a consolidation and those kind of minor things that people make at the beginning. And once we were sure, we would maybe send them back to do a few extra. And once we're finished, we'd say you're now level 3, and we would get them to do an online test. So we developed an online test that would test this objectively. And if they passed, we'd say you're now certified level 3. We then started what we thought was more specific to the level to our study. And so this level 4 is all around our IMCI Plus interpretation framework. And so I'll talk about that just now. But basically, we developed an interpretation framework about how you piece together these different features to try and create those likelihood categories that Prof. alluded to. And so we conducted training in this. And then at this point, we then had an in-person, again, visit where an expert would be with them, and we'd do 5 what we call directly observed procedures. And this was something that we learned in the field is, if you're looking and reviewing things online, it's really easy to see excellent acquisition of beautiful normal lungs. But as our experience had in Namibia, when we were training some people, when we sat and sat with them after they'd done many scans, when they started scanning the chest, they found a huge abnormal mass in the chest, which they didn't know what it was, and so they thought they were in the wrong place. So they very systematically captured beautiful images of normal lung all the way around it. And so if you're not in person, these kind of things can happen. So we inserted this as an opportunity to really kind of round up that standard acquisition, make sure it's still being done correctly. The technique is really flawless after they've had a chance to do many scans by now. And then what we did is we sent them away again to do 10 additional scans by themselves, where they would then again identify all the features. But on top of that now, they would then classify them according to our IMCI Plus interpretation. These are again reviewed by experts, and we confirmed that we agreed with their interpretation or not. And if there were errors that had emerged, we'd send them back to do additional cases, etc. And after this, we had an online session where we'd then again do an online test to objectively verify that. And at this point, we then signed them off as being adequately trained and competent to both acquire good quality images for our study, as well as make sensible clinical interpretation decisions, which they could then use in the randomized control trial. We have a level 5 category as well, and this is really the panel that would be doing all this training. And again, here, just to focus, we're very lucky to have some great, really excellent POCUS trainers who have accreditation from nationally recognized programs, mostly from high-income settings. But we also thought it really important to not disregard that there are many skilled POCUS users in the sub-Saharan African context that don't necessarily have all of these certifications, who we did include after vetting, and then they will obviously trained in our IMCI Plus specific protocol training. So to touch on briefly, we think it's really important that we try and standardize acquisition. I think most people are on the same page around this, and many articles really refer to the same kind of acquisition protocol. What we've done is based on that. All that we've done is we've decided to do what we call anatomical sweeps. And this is mainly, as Annie might mention a bit later, around kind of using these images for automated interpretation and machine learning. We decided to take 6 anatomical sweeps that start at the top and go down to the bottom of the rib cage, anterior, lateral, and posterior. And then if any pathology is seen in that blind sweep, we would then do a targeted view where we do a static video and image over that worst pathology in the region. We also add to this what we call upper quadrant views, looking for spine sign on both sides. So what is the IMCI Plus interpretation framework? So what we did is we set up a Delphi process to try and help us understand, if we can use lung ultrasound to try and better target those entities requiring antibiotics. So we developed an expert consensus statement on the best practice for point-of-care lung ultrasound interpretation in IMCI pneumonia that could really guide antibiotic prescription. And again, to emphasize IMCI pneumonia here, and again, not to diagnose bacterial pneumonia, but really to kind of guide within that context. So we did an extensive literature review and evidence summary, created some expert panels, and we ran 2 rounds of online surveys, and then we had a virtual conference in between to discuss points of contention and to build consensus. And what we did is we created essentially about 27 statements that were split into feature-specific statements and disease-specific statements. So feature-specific statements was really around trying to understand and get agreement around interstitial syndrome, around consolidations and the relevance of sub-centimeter versus intermediate or large consolidations, as well as air bronchograms and effusions. And then for disease-specific statements, we're discussing what we call pneumonia that would benefit from antibiotic treatment. And it's worth noticing as well that, again, there's been a lot of really excellent work from colleagues like Volpicelli et al. And in trying to create consensus here. And I think just to say that this is not trying to run kind of in counter to it, but really to try and make this very contextually specific. So for instance, air bronchograms are very, very challenging for novice users. And so to try and figure out how to build those into an interpretation framework that are kind of reasonable and scalable with kind of novice focus users. So the panels, we had initially a moderator panel with 10 experts within point of care ultrasound, but also those who had very good IMCI understanding and research training experience to create those initial statements. And then we created an expert panel with 15 experts that had really good geographic diversity, specifically and really emphasizing settings where IMCI is practiced and where we would see this being used. And together with them created these statements. So one last thing to quickly touch on as well is now that we've done the scans and we've given advice to the kids, we really wanted to make sure that we had a good quality assurance process. And so we created something called the IMCI Plus faculty. And this is mainly built up of those level 5 experts that I talk about, and again, with representation from Tanzania, South Africa, and Senegal pending, as well as the PER network in USA and colleagues in Switzerland. And the real system for this was just to not get confused by my complex flow diagram. It was really just to show that, for those, the study clinician doing the point of care ultrasound in the randomized control trial would have the option of obviously an intervention or control group. In the intervention group, they could be advised to not get antibiotics. And we felt this was really the highest risk group, that we really wanted to make sure there was a safety net. So all cases that fall into this group would go into what we call a kind of safety check within 24 to 48 hours. And so we'd be cycling between our IMCI Plus faculty, make sure that these ultrasounds are reviewed in real time, and that if there's any discrepancies between the study clinician and the faculty, that this is then flagged for our study coordinators in country, who could then look at the patient record, see did they actually get antibiotics or not? Because as I said, it's possible that the routine clinician decided to disregard our advice. But if the trial did go home without antibiotics, it should have, we can then call them back and engage with him. But just like with all other kind of radiological type studies like this, we would be also doing quality checks and feature identification, with one of the faculty doing a reader 1 essentially, or reader 2 within 2 weeks, and then any discrepancies between the study clinician and the faculty member, we have a third reader within a month. So that's just a little bit of a flavor of where we've come from and what we're trying to do, but just to really emphasize that in doing this and really drawing on a real rich kind of base of work already done, and knowing that there are many people out there doing work in the space, we think there's a really huge potential for collaboration. We really think that when it comes down to ultrasound, I think we really all trying to get to terms with how we define things and how we make decisions on those. And so we feel like we'd really love to share what we've been doing to really make sure we're on the same page about that. And specifically around when it comes to standardizing acquisition and labeling of those images, we think there's a huge potential to really leverage a lot of this for kind of later machine learning type opportunities. And if we do the things right from the very beginning, we really will have a huge resource to kind of build and share together. So we'd be really, really willing to share some of our work around the interpretation, around our training program, and also a little bit about acquisition and labeling. So that's all from me. I'm going to hand over to Grace in Ifakara to take us into what will follow after the RCT in terms of working to the next step, which is really about trying to figure out how to implement what we're learning through the RCT. Thank you.
Thank you very much, Jack, and good evening, good morning for every one of us. As Jack has said, I'm Grace Mhalu from Ifakara Health Institute, a research scientist working on IMCI Plus implementation part, and I'll take you through a bit of what we do on implementation part. Excuse me, my camera is not working correctly, but I think we'll be able to understand. Next. So a quick overview of IMCI IRA of implementation research. It is a component that we want to provide insights into introducing lung ultrasound into routine practices in diverse settings, but also we want to facilitate a more rapid translation of knowledge into policy and practice, as this is part of the implementation research. We also want to establish necessary evidence, policy brief, and operational guides so that they can be used and for sustainable uptake of lung ultrasound in routine care, but also in real-world setting. And this is informed by a co-creation process relevant for stakeholders, policymakers, decision makers, caregivers, as well as community representatives. Next. So the aim of the IRA, the aim is for us to facilitate, as I said, that we can implement the use of lung ultrasound in real world and in routine care setting. So our rationale for doing implementation research together with the RCT is that although lung ultrasound has demonstrated to be safe and easy to use tool, however, little is known about its potential use in low resource and middle income countries like Tanzania and Senegal and South Africa. And this is mainly because its application is scarce and it is limited in our healthcare facilities. But also effectiveness in controlled setting is not enough for us to change policy. So therefore we need effectiveness and cost-effectiveness studies in routine care, along with operational guidelines for implementation in different settings. So therefore, sorry. So the IRA seeks to establish the necessary evidence for policy briefs and operational guidance for, of course, appropriate effectiveness and sustainable uptake, as I've said earlier. Next. So what are our aims and objectives? Our main aim is to facilitate the use of lung ultrasound into routine care, but also our objectives are to co-design contextually appropriate implementation strategies that I'll talk about a bit later, but also determine effectiveness in routine care as opposed to clinical controlled trials, but also generate insight on facilitators and barriers to effectiveness, sustainable implementation, and facilitate knowledge translation, and also develop and test deep learning algorithm. For the last objective, I will not talk about it. I think Anne will come in and talk about it. So the decision to implement, whether to implement or no, will be based on the RCT and other studies, as I'll share a bit later. Next. So this is our study design. We will have 2 phases, and currently we are in phase 1, where we are co-designing implementation strategy that we will also integrate into lung ultrasound, but also based on the shared understanding of these services, provision and facilitators and barriers, and adaptation of these co-designing workshops and strategies, we'll move to phase 2, where in phase 2, we'll do an iterative approach where we will pilot and refine our implementation strategy before rolling out. And we'll do effectiveness, kind of hybrid implementation design that I will talk in the next slide. So we have 2 phases for the IMCI plus IR component. Next. So for phase 1, we will do, as I said, co-design workshop in mixed method studies so that we can be able to understand current service provision, also understand acceptability and perspective and user priorities for its introduction in routine care. Also explore perspective on antibiotic use, resistant stewardship, and also we'll do this for 6 to 9 months alongside RCT, but we also do this in RCT and non-RCT facilities. So we are going a bit broader and not only doing the implementation research in RCT facilities, but we will include non-RCT facilities so that we can be able to test effectiveness of these if we introduce in routine care, even in non-RCT facilities, which is also cost effectiveness. So we do a lot of semi-structured observation, qualitative interviews, caregivers focus group discussions, and stakeholder key informant interviews in this phase. Next. So the second phase will do, as I said, effectiveness implementation hybrid design, where we will look into effectiveness study, but also into implementation study. For the effectiveness study, we'll do quasi-experimental pre-post design studies, observational studies, so as to assess adherence, effectiveness in both RCT and non-RCT naive facilities. We will also, as I said, embed mixed method studies where we want to look at uptake, quality of care, fidelity, barriers, acceptability, intended and intended use. And this will be doing in 2 to 4 facilities per site in all sites that are doing RCT, IMCI RCT. Next. Next. So our study population will go a bit further and include not only, although the intervention is targeted to children with severe, non-severe pneumonia, but we'll go a bit further and include all children with cough and difficulty in breathing. So that as classified by IMCI, so that we can be able to understand broader context, assess fidelity and unintended use, but also for us to be able to do sub-analysis to have for non-severe pneumonia criteria for these other groups. So we are going a bit further and including more children as restricted, as not in the RCT, but not as restricted in the RCT part, so that we can be able also to assess these other effectiveness study objectives. Next. We will also do, our study population also include healthcare providers, as I said earlier, where we'll do in-depth interview service provision assessment, so that we can be able to evaluate service provision, acceptability, feasibility, and compliance. We'll also include caregivers of children who IMCI plus will be used on the consultation, the lung ultrasound, in rapid interviews, so that we can be able also to assess acceptability and satisfaction of provision of care for this study. Next. So we will collect different data and structured data. For unstructured data, we will collect qualitative observations. These are handwritten notes. We'll also do a lot of documentations. We'll take pictures and images. But we will also use repository restricted access data, which is raw audio recordings that we'll be getting through our observation during data collection. Next. We also collect structured data, as I said earlier, for the co-effectiveness study, but also for the implementation part studies, where the data will be collected through ODK and This will also help us to assess effectiveness in both RCT and non-RCT facilities. And with this, thank you very much, Jacques. I hand it back to Leith. Thank you.
Great. Thank you so much, Grace. And a big thank you to our 4 representatives from IMCI Plus. So now we have 10 minutes for questions. That was a huge amount of information that was just shared, or comments. So you're very, very welcome to put those in the chat and we'll call them out, or feel free to come off mute, raise your hand and speak. It's always tough to ask the first question, but I'm sure there are questions based on this huge body of work. If there are no questions, we can move directly to our round robin, but I just want to give people a little bit more time to seek any clarifications. Christian, and if you could introduce yourself and your institution, that would be terrific.
Yeah, hello, this is Christian Schmidt. I'm from Germany and worked for 3 years in Tanzania, and I'm the project manager of the International Pediatric Ultrasound Network, where we start trainings in Malawi, Nepal, and Tanzania, POCUS trainings as well, and we are doing that since like 8 years, and the program, the IPUN program, started 2 years ago, and Robert Moshiro is as well a part of the program in Dar es Salaam. My question is concerning the devices. So in the pictures, I saw butterfly devices. So how could you get the devices for all different settings where you worked in, and as well to make sure that everybody who's willing and keen doing chest ultrasound, which I like a lot, so that everybody can use it as well during the calls or as well on the ER. So how did you manage that?
I'm happy to jump in if that's not too presumptuous. Hi, Christian. Thanks for the question. Yeah, so I think so I suppose when we set up the IMCI Plus consortium, our kind of industry partner was actually Butterfly, or is Butterfly, and there are actually a few Butterfly of the team on this call. So good to see a few of you here as well. And I think basically many of the consortium group had used butterfly probes before in a few other studies, and at the time we really felt it was a really good and kind of general all-use type probe. And so we saw a kind of, and in a way, I think also precipitated a lot of the study is these kind of the advancement of these new handheld probes that can really be plugged into tablets. And so many of the settings in which we're working don't have ultrasound machines available. And so it was really essential that we had something that was portable and something that we could really bring to those places, but also something that we saw as potentially scalable beyond our study as well. And so we've partnered with Butterfly, who've been supporting us, although we have purchased our probes for all the different sites in which we're using them. And we also see it as a really great opportunity from a research point of view to make sure that we're also bringing value to the places we're at. So at least, for instance, at many of the South African sites that we're in, you know, the probes are kind of circulating, they're available for the doctors. We've often run kind of concurrent training programs on the side around, you know, looking for DVTs and basic obstetrics, except so we kind of see it as a good way that research can also bring kind of access to certain tools during the course of the study, and the intention as well as after the course of the study that these probes through the implementation research project, where things will be given to the clinicians where they'll be using it, and those probes will kind of have a longer life lived in those facilities kind of well after this project. So that's, I hope that kind of answers your question.
Yeah, thank you very much. Very impressive.
Thanks, Jacques, and thanks, Christian. Any other questions? Chris, welcome. Great to have you here, Chris.
Thanks, Leith, and thanks, Jacques and Christina and everyone. Really wonderful presentation. So I'm Chris Reese. I'm a pediatric emergency medicine physician and a clinician scientist in the Child Health and Mortality Prevention Surveillance Network. And very interested in prognostic and diagnostic research related to pneumonia. I love this study, and I've known of it for some time, and I'm a big fan. My only question is, has there been, I often see these, young infants with what we would call clinically bronchiolitis, but they do meet severe pneumonia criteria and oftentimes get started on antibiotics in the inpatient settings. And I apologize if I missed this somewhere, but has there been any thought of extending this to inpatient settings to potentially withhold antibiotics from children with presumptive bronchiolitis who may not need antibiotics as well?
Again, to kind of avoid silence, I'll keep jumping in, but please, Christina, anyone else?
No,
Please feel free
actually,
to.
we did assign Jack to all those technical questions, so that's why he's speaking. It's been planned like that. Go ahead, Jack.
I just don't want to come across as rude as the really eager guy to speak. But thanks,
Never,
Chris.
never, Jacques. Yeah.
Appreciate your question. Yeah, so I think I mean at this stage many of those kids would fall under the definition of kind of IMCI pneumonia, and so it really comes down to what we've seen, and a lot of the kind of criteria around give antibiotics or don't give antibiotics does kind of draw a lot on studies that kind of have looked at bronchiolitis and the kind of lung ultrasound features within bronchiolitis, say versus a kind of more classic kind of bacterial pneumonia, and so. Although it's not necessarily aimed at inpatient, those that meet criteria for our inclusion at the clinics, some of them will get admitted, but that doesn't necessarily mean they're excluded. So there are obviously a lot of exclusion criteria based on severity. So those with very low saturations, those with kind of severe signs of respiratory distress, specifically distress and SATs in very small children. So there's a kind of severity exclusion criteria because we just really think that's a high risk group. But we have tried to kind of create some cutoffs that allow us to include some of those relatively comfortable bronchiolitis kids who are being admitted for oxygen and kind of symptomatic therapy, and we do advise for no antibiotics in those, and we know that they're being admitted and we're watching them. I think where it does become challenging as well is some of them, the consolidation sizes on some of them are where a lot of this debate is, because many of them have kind of interstitial syndromes and have these small kind of sub-centimeter consolidations. And so in our interpretation frame, we've tried to account for those, but we've for a safety reason set the threshold quite low for giving antibiotics for obvious reasons. But we think there'll be potentially quite interesting data that comes out of it when we're able to start looking at these subgroups and see how they fare and how many of them had to be started on antibiotics within a certain period of time, etc. So there will be an admitted portion, and so far, at least in the South African settings that have kind of already started, quite a few of the kids, because we're based at kind of district level hospitals, there are quite a few admitted children already, probably maybe more than we would get from, say, the Tanzania site.
Thank you, Jacques. Happy to call on Yassir. I was hoping we would hear from Yassir. Welcome.
Thank you very much, Leith, and thank you, Christina, Jack, and everybody. I'm very excited about this study because it is one of the key questions which we put during the update of the pneumonia guidelines. By the way, my name is Yassir. I'm a pediatrician and epidemiologist working for WHO, specifically on research and development in the area of newborn infection, pneumonia, and diarrhea. Two important questions here. One is that we know that now PCV and Hib vaccine is on a higher side in many of these countries. And these pneumonias are mostly viral pneumonias. Do we have something around that information? Are we collecting this information, not at the individual level, but at the population level, where we are working in these 2-3 countries? Second important thing which I would like to discuss, because of we don't have a gold standard diagnostic criteria for pneumonia, and but we did it in the guidelines. We tried to see how much ultrasound is sensitive to the criteria which different studies as considered as a reference criteria. So in your study also, we have seen that the criteria is slightly different than many other studies. So have you done something to have a uniform criteria other than the IMCI, which is in the first 5 years of life, but beyond 5 years of life, we don't have such a good criteria. So do we have a specific criteria here, which is more generalizable to be used in the future? And lastly, I still not understand the relationship between IR and the trial. So how you will put this IR with the trial or without the trial? What is the relationship with the results are slightly different, I believe, from the two, but how you will interpret those results in terms of policy making and for the implication of those results in the future. Thank you very much.
Thank you, Yasir. Maybe I can talk about the first questions. I think they really relate to how can we work together to build a larger cohort, even beyond the study, on using lung ultrasound. And I think that's really, really key. So in our study, clinical outcome, as you know, is an important reference standard, actually in hindsight as kind of a retrospective gold standard. We do collect minimal inflammatory markers, CRP data, and also minimal microbiological data in our study to create a nested cohort study. But really the idea is, how can we create a platform, so a platform trial observational cohort that actually uses those standards where we harmonize and where we can use triangulation of data to answer some of the questions that you're specifically interested in. So we already shared the protocol with colleagues, and an additional site in Ethiopia is currently joining with a large observational study. So really also what the goal of this webinar is, how can we move forward together as a community and share some of the important resources that we built together as a group, and you were included in that over the past month, to make data useful and also to make future data collection useful. Because any single study, I think, will be too small and not enough contextualized to answer some of those questions. So some of the data we're collecting on vaccinations will be collected, and we're attempting to collect a minimal set of microbiological data and inflammatory markers as well. But again, having the clinical outcomes and the standardization of the chest ultrasound, how it's collected, how it's interpreted, and to harmonize protocols will be quite important in the future to answer some of those questions that you have. And I'll leave it to Grace for the...
If it's okay for 2 seconds, just to quickly add one last thing, and that is just to say that from a sample point of view, we are collecting, as Christina mentioned, we'll be collecting saliva and nasopharyngeal swabs on as many as we can, particularly in South Africa and in Senegal, and the saliva in Tanzania, to try and get some of that. But I think, as you know, the attributable fraction is always a challenge. And so we're working and partnering with the group in South Africa, the National Institute of Communicable Diseases, who've done a lot of work on this as well. Many of them have surveillance sites as well that capture general pathogens floating in healthy controls. And we'll be working with them to try and see if we can generate some meaningful evidence around that. And as for the kind of sensitivity of LUS compared to other reference standards, I think, as you know, in a way, lung ultrasound is almost too sensitive to some degree in seeing pathology that chest X-ray doesn't, and so doesn't always feel like a fair comparison if you use chest X-ray as a gold standard. But I think we will also be kind of opportunistically collecting chest X-rays from all cases that get them in the settings in which they are. And I think mainly because of the difficulty of getting this gold reference standard, I think that's why we've kind of rolled the study out in a pragmatic way, and trying to really affect care and using that and kind of outcomes also as a proxy. Just to clarify, it wasn't clear earlier as well, is that technically our sample size is set for under 5s, and that's really what we're powered for. But we will be including kids 5 to 12 years, or up until they turn 13. and very much trying to gather this information as well around clinical auscultation, ultrasound, etc., to see how we could put this together to try and better understand what would be kind of more effective ways of classifying and diagnosing those children in most need of antibiotics.
Thanks, Jacques. So we need to keep moving shortly, but Grace, would you like to add the final comment there before we pivot to the next session? Do we still have Grace? Maybe not. Okay.
Grace might have had a connectivity issue, but so basically, I see what though it seems disconnected, the two studies are integrated. So we will use, as you know, the first part is still in quite a controlled setting because we're not exposing the routine clinicians to POCUS, and we'll try to integrate the data from the IR and the RCT to actually answer question effectiveness, to try to short track the answer a little bit. What do we see left of the effect when we go into real world settings? So the IR is designed to give information to the RCT data to be able to model those questions.
Thanks, Christina. Okay, we need to keep moving because we have to get all of you in. So we're pivoting now to this session we've called a round robin. So the whole purpose of this call is towards a community of practice. So we need to have a sense of who's doing what relevant work. And in the agenda, we asked you to think about sharing any relevant ultrasound research published in the last 5 years or currently active, and we should have added or planned. So we want to go around and hear from those groups that fit that criteria. And if you could give a less than 2-minute lightning update on the research and drop a link into the chat at the same time, this would be the perfect way to do this. So start getting your sort of rapid fire updates ready. And if you could raise your hands and we'll go one by one. We don't want to miss any important work that's being done in this area. It doesn't have to relate only to children. It doesn't even have to relate only to lung. It's point of care ultrasound. So who would like to kick off? I am kind of drawn to inviting you, Giovanni Volpicelli, to step in here as a leader in this field. I know you're traveling and you may not be able to come on audio, but if you are and don't mind sharing some of your work, that would be great. Giovanni.
Nate,
Yes.
you listen to me?
Yes.
I'm really sorry. I'm driving now, and I only had the possibility to listen to very few spots from the connection. And I must say that I find very motivated people. That is surprising for me. Our main target is in these years to try to make scientific societies more aware about the potential of lung ultrasound, especially the use of lung ultrasound in scarce resource areas. That is the main topic that I think is the future of lung ultrasound. So I'm so happy to see so many people involved in projects and using lung ultrasound, and very expert people. That is quite surprising to me. I don't find the same level of expertise in very advanced hospitals in Western countries. So it's just a way to understand that the main place where lung ultrasound can be very impactful is scarce resource areas, and the use for pneumonia in children is a topic that is very promising in the future. The only point is that we should never forget that lung ultrasound cannot allow us to finalize the diagnosis. Lung ultrasound is a method, it's not a diagnostic tool, it's not an imaging diagnostic tool, it's just a clinical method. And this should be never forgiven. I mean, it is very important that we consider lung ultrasound as it is. When we visualize a consolidation, we don't know why the patient has a consolidation. So the only possibility we have to interpret correctly the image is to consider the clinical context and the main information from the patient. So this is the only thing that I can say now, and I hope in the future there will be the possibility to collaborate with these people.
Excellent. Thank you very much I know it's difficult for you to come off mute when you're driving, but we appreciate that. And I think there's deep appetite to work with you and your team from the IMCI Plus perspective. But let's get others in.
Absolutely. I know Giovanni has talked too much already, but Giovanni, just 1 minute maybe on some of the, I know your group is working on guidelines as well and guidances. Do you want to give a 1 minute comment?
Yes. We are now working. It is a long work we are doing from years. I think we only stopped during the COVID-19 pandemic, and then we started again. And now we are finalizing the update of the International Consensus Conference. I know there is a confusion about the topic because there are many groups around the world trying to make consensus statements on lung ultrasound. But the process we are doing is only focused on the clinical application of lung ultrasound, only dedicated to lung ultrasound. So we are not dealing with physics of artifacts, with other topics, only clinical applications. And we selected a very strict group of very short group of experts based on literature selection, very strict criteria. So having published at least 2 main papers, original studies on lung ultrasound in very high ranking journals as first authors. And these selected just 22 people working hard to update the lung ultrasound new statements. And we are we started from the old consensus, and now there are a lot of evidence about new applications. And one of these is the way to make the differential diagnosis of consolidations. And I think in pediatric application, this is very important topic, and especially for the diagnosis of bacterial and differentiating bacterial pneumonia from viral pneumonia and so on. So in the next future, I hope in a few months, we will have a new publication. And I think it's very important for the community to have a guide on the application of lung ultrasound. And again, I recommend the consideration that lung ultrasound is just a method, is not just like chest X-ray on CAT scan. They are totally different. Lung ultrasound allows us a clinical method, and this is something that should be applied in these areas to help the population and to help and to improve the diagnosis of bacterial pneumonia and to optimize the use of antibiotics in this area. So thank you for the invitation. I hope in the future there will be the way to collaborate more.
Great. Thanks, Giovanni. Others, we need to hear from others, and the clock's ticking. So please, great. Sheila.
Yes, good morning, everybody. Good evening, good afternoon, depending on where you're joining us from. First of all, I'd just like to say a big thank you for convening us together to share our work and such great work being done all around. I work with Global Ultrasound Institute. We do point-of-care ultrasound training and education across the globe of importance. And just to share the work we've previously done is we have partnered together with other institutions in South Africa and in Kenya to train on obstetrics point-of-care ultrasound. So we did a 1,000 probe deployment that was funded, and we deployed 1,000 probes both in South Africa and in Kenya. Started in 2022, just winding up in South Africa. We are currently working on another project in Ghana on obstetric point of care ultrasound, and another one still in Kenya together with the Ampath Population Health. We are working on heart failure and breast masses, as well as obstetric point of care ultrasound. All this is done with in mid-level facilities and the low-level facilities, those who are far away from technology and from diagnostic capabilities. And we just hope to see the great impact of the trainings that we have done. The just concluded one in South Africa has so far achieved, so 1 million scans have already been done, tracking from the devices. 1 million plus scans have been done, and those are 1 million lives touched. The mode of our training is, first of all, online. We have online modules on our learning platform that is very robust and that offers all point of care ultrasound applications. After the online learning is done, we do an in-person workshop that allows the learners to have hands-on scanning practice. Once we finish the in-person workshops, we do longitudinal mentorship with quality assurance for the scans that have been done. So our website allows learners to be able to send in their scans and have experts review their scans and give them feedback. This tends to give the users a bit of some confidence, because during the training, we realized that some people have when the people are in a group and they're helping one another, they're able to do this. We also do evaluations, both theoretic and practical evaluations using OSCEs. Once we finish that, they are able to now do individual independent scans, send them over, and we store them, first of all, for QA, and they are able to be reviewed and given feedback. This builds their confidence and ensures that the work that they're doing is actually to standard. We
Thanks.
are global as
Sheila,
just...
Yep, Sheila,
Okay.
we have to do very, very brief. You don't have to describe the entire program, but very brief overview, and then put the links in the chat so people will go to that. So I'm sorry to cut you off, but we have to get through all these other speakers. So did you want to wrap up?
Yes, I think that's it. I will share our links on the chat. Thank you so much.
Brilliant. Thanks for your understanding there. Amy Ginsberg.
Hey, so this was an amazing call. It's really impressive, this project. I'm so grateful for the opportunity to hear about it in detail. So in terms of what I'm involved in the great Gio Volpicelli's project of the expert panel, the second International Consensus Conference on Lung Ultrasound. And I'm happy to hear that it might be wrapped up in the next a couple of months. I'm also involved working with GE Healthcare, who got a grant from the Gates Foundation around developing AI-assisted lung ultrasound and AI-assisted obstetric ultrasound. So for the lung ultrasound, identifying consolidations, pleural effusions, and interstitial and B lines. And we're doing that work in Nepal and Kenya and Nepal and Rwanda, the lung ultrasound work. And then the obstetric ultrasound, we developing a whole bunch of algorithms around gestational age dating, multiples, et cetera, et cetera. There's like 9 algorithms, and that's work being done in Nepal, Ethiopia, and Kenya. Thanks for your time.
Perfect, Amy. Thanks so much. Feel free to drop any links into the chat. Justy.
Yeah, thanks, Leet, and thanks for the inspiring talk, everyone. I'm Clinical Director. I'm Justy Anthony Chirmal, the Clinical Director for Global Health at Cure.ai. Towards our work in POCUS AI, one of the main things I'd like to draw everybody's attention is that we are contingent on funding. We are developing an open source. We are proposing an establishment of an open source database of lung ultrasound for both TB and pneumonia in both adults and children. In that context, I've reached out to many of the folks who are there in this meeting. So just wanted to let everybody know if there is interest and if they have the right approvals. It'll be a great way to contribute to the ecosystem so that developers like us and others and researchers can use this to advance diagnostics in the space of pneumonia and TB. I will stop here. Leith, thank you so much for this opportunity.
Thanks, Justy. You might want to drop into the chat as well a good link to Cure.ai's ultrasound work. So check that out. Thank you.
Thanks.
Veronique.
Hi, everyone. Really amazed by this call, as many of us. For time's sake, in a nutshell, I've been working the past few years on the TRUST study, triage ultrasound in TB endemic regions, together with Ablo Wachinou on this call, Noémie Boya, and Marianne Hartley. We had a first diagnostic study on TB detection with LUS interpreted by humans and by automated detection with AI. And we had quite promising results in this spin-in cohorts. I put the preprints and the results in the chat. Our future projects are granted through an EDCDP grant, and we will do an external validation in Mali, Benin, and South Africa, also thinking of a platform design to have extension to other sites and other continents. So an external validation, and then later in this 5-year period, we will also do implementation research in more real-life settings. And I think a logical step would be, because I'm focusing on symptomatic patients for TB triage, a logic step would be to go to someone of Elsa Swinkel's team who are also EDCDP granted and who are focusing on screening, if I may.
Yeah. Elsa, did you want to come in?
Yes, thank you. I could follow up on this. So we indeed also did a study very similar to Veronique Suttel's study, then in Zambia. And in that study, we included symptomatic persons as well with a 16R5 zone acquisition protocol. And we also trained an AI model and got very promising results. And now, based on these results, we also have a follow-up study. It's focused for TB. It's NIHR study, and there are also some other persons from this grant in this call. We plan to do some work in Peru, Bolivia, Zambia, and Mozambique. And this is all focused on TB. Then we are involved in this EDCTP project where Veronique was talking about, which is about pneumonia and TB and chest X-ray and ultrasound. So we have different use cases there. And we are planning to do a study for asymptomatic TB, indeed, where we include persons, and we do a chest X-ray, ultrasound, and symptom screen, and then we see if that person had TB or not. And next to this lung ultrasound work, we are doing a lot of work in obstetrics and baby checker at Delft Imaging. So I didn't introduce myself, but I'm a deep learning engineer at Delft. And we developed some AI models to detect risk factors during pregnancy. So also gestational age, multiple pregnancies, placenta location, and those things.
Thank you. You can drop links into the chat. I want to bring Emily in.
Hi, good evening, good morning to everyone. Just talking on behalf of Megan Palmer, who is connected but has a bad connection. We're currently working on a project called Decide TB, which is focusing on diagnosis on diagnosing childhood TB. And there's a sub-study that will start hopefully by the end of the year called eHealth for Child TB, where there is a long ultrasound component with a comparison to chest X-ray. And we were very happy to learn about your study and because all the scanning protocol and training plan is not developed completely yet. So we hope to align with IMCA Plus, hopefully. And the project for the sub-study, it will happen in Mozambique and Côte d'Ivoire. Thank you.
Brilliant. And Erin, I'm glad you raised your hand. You've got a note in the chat, but go for it. Erin Strata. Erin, can you come off mute? Maybe not. Let's go to Suraj and come back to Erin.
Yeah. Hi, everyone. This is Suraj from London School of Hygiene Tropical Medicine, UK. I have been running a project on long ultrasonography to diagnose pneumonia in under 5 children in Nepal. We have already enrolled 300 plus children. Our inclusion criteria was not IMCI, but WHO-defined pneumonia because it's a mid-level facility, and IMCI protocol is no longer used in the facilities, basically in the community and primary care. So I also had a question around that for the team. Why you choose IMCI, and because in the facilities in tertiary level care, IMCI is less used because there are consultants and specialists who rather use other tools. And then the MCI is used usually for the community workers. So anyway, so I'm collaborating with Vero, Neil, and Christina, and Jack. So I think we had a call before. So it's very good to be a member of this community. So I'll be happy to share the findings with the community once we analyze the data. And we're also looking for a team to streamline the review criteria, etc. So and also the gold standard determination criteria. So it will be very helpful to keep in touch. Thank you, everyone. And if anyone wants to expand the your study sites in Nepal, so I'm happy to coordinate here. Thanks.
Thanks, Suraj. Please drop links into the chat. Erin, we're going to try you one more time, then I think we're going to have to move.
Can you hear me now?
Yes, go ahead.
Great. Sorry about that. I'm biking and texting at the same time.
Oh, no.
I'm Erin Strata. I work for Médecins Sans Frontières, Doctors Without Borders. I'm sitting in for Carla Schwanfelder, who is our pediatrics liaison for all things POCUS in MSF. So feel free to reach out to us. We have a few studies published, a few others that are in the pipeline. We do a lot of ultrasound on pediatrics. We're passionate about lung ultrasound for peds, and I'm really excited to see the call to action here. Thanks.
Great, Erin. So we're going to move to the next and final session, which is probably the most critical one. If you did not have an opportunity to share your update, please drop a note in the chat with links and we will be sure to include it. But I want to pivot now to introduce Annie Hartley. So strap on your seatbelt. Annie's going to really take all of this information that's just been shared and provide a path forward for how we can actually build a community of practice. So Annie, over to you.
It looks like we do need seatbelts in this call. Everyone is on different modes of transport. So please do it. And I'm sorry, guys, I'm in a very yellow room. It feels like I'm on the inside of a gallbladder. It's not my choice, but trying my best, right? So my name is Annie. I am a professor of AI. So obviously that's going to be definitely one of the topics we're going to touch on today. Why do we bother making sure that all of our data is interoperable? It's a lot of work, or it can be. Sometimes it doesn't have to be. Why do we even bother to not do the same mistakes or just continue on the path that we were doing with mHealth, where we have these fragmented efforts? What is the real incentivization that we can have to do this? So I'll be speaking on behalf of IMCI because I'm a very proud member of it, and I really love to see the work and the interest of everyone here. I'm based at Light. I run this lab called Laboratory for Intelligent Global Health and Humanitarian Response Technologies. And it's a very interdisciplinary lab because what we're trying to do, which is really like what we're going to try to show that we can do together, is collaborative science. And to make sure that we can get a whole lot of people together that are doing similar things to make sure that we can break through these fragmented efforts. Because the thing is, when you're working with AI in this day and age, like it's so tiring. There's so much activity, and the new tools simply don't work with small amounts of data. It's not just like a logistic regression like before, where you could have like an individual study. These tools, if we really want to leverage their power, these large language models and everything, it actually necessitates the large data. We can't get around it. And so we do have to try to make special efforts to ensure that we can still participate in these studies, represent our smaller populations, and actually respond to the responsibility of ensuring that we do that, right? Because it becomes an ethical need to do that. So what we're doing is we're making scalable tools, and this still diagram that I've got here is quite important because I'm going to show you 4 different ways, very concrete ways that we can collaborate right now based on this diagram. So I've just kind of like put it up here. But it's also it's emblematic of what we're doing in general. We're trying to make scalable tools because this is what big data and these big studies are doing. We're trying to ensure that they are genuinely implementable, making tools that you can use now, right? To ensure that we can collaborate together and that we can make evidence that shows that whatever we are doing is provably impactful. So this means that we collect data, of course, and this is what everyone is doing here, is collecting data. And obviously what we're trying to do is align that, right? To ensure that we can come together to make AI models, which is, down here. And we make any kind of AI model, including foundation models, multimodal, so like ChatGPT type models, but ones that are adapted for a low resource setting, that we can own, that we can trust, that we can make sure that it's open, and that we can use in different settings and contextualize to those settings. Very important that we're able to do that. But before we get to this point, you can see that there's a very important thing in between there, which is the management of that data. Why don't we all just, hold hands and sing kumbaya and share our data in a big pot, and make these centralized data sets? I've worked in these settings for a long time, also with during the Ebola epidemic, even when sharing data was urgent. I mean, it was so scary, the Ebola epidemic in Sierra Leone, and I was there, and still, even that, no one shared their data. It took 6 years for the data to finally be coalesced into one big pot. And by then, of course, it was completely irrelevant. So this has happened time and time again. And now we are trying to develop technologies that allow us to, and data isn't shared for a range of very well-considered reasons. So it's better to maybe respond to that and say that allowing people to contribute to models which they want to contribute to, but still keeping the sovereignty and ownership of their data, which is sometimes very difficult to give up. So I'll show you a technology today that you can keep the ownership of your data, never share it, but still contribute to the actual models that we are building, right? And then all of these models that we are building, you just heard today, there was another model there were 2 models that have been made that are really promising for tuberculosis detection, for instance. So which one is the best architecture? Maybe one is a better architecture for one place, another is for another place. You'll never know if you can't test all of them and have that test bed that can be a safe environment. And not all of us are data scientists here, right? So it's important to have this code-free interface, to have these accessible tools that you can just use and out of the box. And then finally, we of course make things into that interface that can interface with the practitioners so that the data owners themselves can use those tools, and also not recreate the wheel every time we're doing something, so that this person can rather just nudge a model and move that model into their context, okay? And then, of course, what we are all here for, randomized controlled trials, showing evidence of efficacy so that we can have policy change, right? So these are all the important concepts. So now they are going to be broken down into very, very concrete tasks and things that we can do together, and actual tools that we can use. The first one, what we are here for with the trials, we are launching a platform trial for this. It's a very specific and protected word, like if you know what a platform trial is, and it's a very simple concept. It's basically just allowing us to follow a set of core principles, right, that we have to follow, but that we can, it's an ever expanding trial that can evolve and allow any number or combination of countries to join in, or regions or hospitals, and to follow a set of principles so that everyone can still have their own trial, but still contribute to something bigger from the beginning. You can use all of the paperwork and everything that's been made by a consortia of people, and it reduces the friction to start these kinds of trials and the cost, allowing us to rather recruit more patients because we know that these interventions improve care, and focus on that. The second thing is DISCO. And of course, I spent more time on the logo than on the platform, and I'm very proud of it. But you'll see that this stands for Distributed Collaborative Learning. And the Disco platform will show you a live demo. It's working end to end, and we can use it today. It's for data owners who want to contribute to a model, maybe some of the promising models that you'll hear about today. That we've got one that's called Ultra AI here. We've got a foundation model for medicine in low resource settings. And you can actually contribute to these models without giving up the ownership or sovereignty of your data through this platform, right? And I'll show it live. And then finally, once you have these models, maybe you just want to nudge them, especially these ones that are conversational interface. We've all tried it. I'm sure you have. Taking a large language model like OpenAI and dropping an image of like an ultrasound or something in there and getting some feedback on it. And right now, like we can test it live if we have any time, but you can see if anyone wants to do that now, you can go and take a lung ultrasound image that's obviously got de-identified and stuff, put it into OpenAI and see how it interprets it. And sometimes it will get it right with like B-lines or something like this. But as soon as it gets more complicated and contextualized, it just fails, right? And so we have got a really promising model that you can actually, the 70 billion parameters is the size of the model, very, very affordable to host locally in low resource settings and can be locally owned. And we can, if we have enough data, make a foundation model that actually understands and can automatically interpret some of these things and help us standardize interpretation. So it's a suite of foundational and AI models that we can use for specially adapted to our settings and to contribute to that and to make sure that you are fulfilling your responsibility to represent the people who you represent, right? Everyone's coming from different countries and we have the responsibility to represent them in these upcoming models. And they can be for any model. It doesn't have to be ours. It can be, Elsa has got a great model as well. We've got, any model can come in here and you can use the one that is best suited for you, right? And then finally, we have this model moving platform, which we called Move, which I also end-to-end working open invitation to join. And it's called a massive open online validation and evaluation platform. And this is a way to take any model and to nudge it toward your setting by giving it critical feedback and therefore building the model with your expertise. You don't have to know AI to be able to participate in this kind of technology. So without further ado, you kind of get the vibe of where we're going for this. I'm going to give you some eye candy for each of the 4 points. And these are clear, concrete things that we can collaborate on. So firstly, here we've got the platform trial. And just to give you a little snapshot of what that means, it's a bit like fuzzy, I don't know why, but you can see here that we've got a core protocol. And if you wanted to join in, what you would do is you would make an appendix of a country profile and a use case. So maybe yours is like tuberculosis detection in the community in Ghana, right? So then you would have like a use case here and you would have a country profile and you would be able to just add those in and then contribute to the core protocol. This is an example of some of the platform trials that we are doing. And it makes it reduces that so much. There's so much less friction because the data management plan is there, the statistical analysis plan is there, and you can still have your own trial, but contribute to something bigger as well and ensure that interoperability, right? And to have a single kind of convening body that represents all the different countries in an international consortium. So open invitation, let's do this, right? So that's something that you'll watch the waves for in this consortium. The next one is that I just wanted to actually skip over here and skip over the data management part and go to some of the models just to show you what Veronique was saying. I'd quickly put this in here just so you can see what she was saying, right? So she said, hey, we've got this model and it's performing really well. Well, here's a rock curve of how the AI models can perform. We asked our AI model, we said, here's some images, right? Now try to see if you can predict tuberculosis from these images. And if you know rock curves, this over here is like is random, right? So if you are over here, it's random, and over here, as soon as you get closer and closer to 1, it's perfect detection of tuberculosis, for example. And I can tell you that humans, just looking at with their eyes, they're around over here with if they try to predict tuberculosis, right? We are near random. We're not good at doing it. So this is not replacing anyone. It's really creating some extra space for us to predict something that we normally can't do by ourselves. And so here, if we throw these images into the model, it can actually see all of those elements that we struggle to see by ourselves. and it reaches the WHO criteria of sensitivity and specificity, which is 90% and 70%. It reaches it comfortably when we are doing different kinds of modeling with our tools. So this is the potential of something that you could contribute to, right? So this is great for Benin, but is it good for you? And so we need that space for you to be able to test your models, test your data, right, on these models, test these models, and to see if it would be worthwhile contributing. And I can assure you it is. For instance, you know what was interesting? So I know we don't have too much time, but it was just, this is a good example. So this over here, these are coming from Benin, right? If we try to use this same model in South Africa, it doesn't work so well. Why? Because and that's why we have to change it, because in South Africa, we actually have a huge obesity problem. And if you are losing weight due to tuberculosis, which is obviously a key sign of tuberculosis, you can't see it as much in South Africa, but you can see it more where the average BMI in Benin is much lower. So our ultrasound picks up the BMI as well on the in its evaluation, and it uses it as part of its reasoning process. Whereas in South Africa, it has to be focused much more on the lung, right? Because in general, we are a larger society because we have a larger BMI. That's really important, right? So we do need representation to ensure that these models work for your communities that you are representing. So over here, now we can pass to, if you wanted to get to this point, how do you actually do that, right? Do we have to go and sign a DTA and wait 6 years like we did with Ebola? I certainly hope not, right? So what we're going to do is we have something called distributed collaborative learning now. This is maybe you, this is us, this is someone else, and this is someone else, right? And what we want to do usually is there's a big copy-paste problem, because at some point you've got to go put your data on a drive somewhere or on a cloud, and you Control-C and you Control-V. And that is uncomfortable. And it takes long because it's up to you to decide that these are protected in terms of privacy, that your IP is not going to be taken away by this server who is usually in a higher resource setting, and you have this loss of ownership. And often the person in the higher resource setting is the one that is benefiting from all of this, right? You lose your intellectual property often when you give up your data like this. And these are the real reasons why people don't share. It's the things that people don't say, you know. It's laborious to do this. And what if you don't have the time to do it? So we want to find an alternative where we don't have to actually have this privacy risk, because privacy does degrade over time as our models are improving to detect it. So what we want to do is make sure that there's some sort of equilibration here, and we can make sure that, you know, if one person can't share their data because they can't go through all of this nonsense, we don't get this unrepresentative data in our models. So how do we do this? Well, there is a solution where instead of sharing our data to the source of the model, right? Here's the model with the server. We rather share the model to the source of the data, and we flip the archetype, right? And then the model learns in place, and everyone wins because we get better models, but we also get, like, we're allowed to train these models in place where they give updates about what they are learning to the server, and only those abstract updates which coalesce into something, and we provably learn the same model that we would have learned if we did share our data, and everyone gets the same model, right? Now, this is actually something that we can demo quite easily right now. So I'll quickly do that and show you exactly how this works. And if you wanted to do it, you could even go to this website. So I'll just show it to you. I'm sure you're still seeing my screen, right?
Yes.
Cool. All right. So over here in the chat, I'll just quickly also just pop that in there, right? So this is one of the examples. And over here, you'll be able to see that DISCO. Okay, first of all, it stands for distributed. Now you understand why it's distributed learning, because the model is learning in that distributed way. And it does what it says, right? Train AI models together, but keep data private. Building your AI tools without sharing any data. And it's as easy as this. You have your data and no AI training. You can start training over here, and you can say, well, I want to go and look at lung image classification. So you've chosen a model. You can see that there are a few things to do up here. So one is I've selected a task, which is like my lung ultrasound task. I thought it sounded interesting, and I've got some data. Now I'm going to go read the task description about, oh, this is lung ultrasound image classification. There's a model here. There's some parameters. That's pretty interesting, but I don't really care, right? I just want to train a model. You can read it if you want, but you've done nothing yet, right? Next, You connect your data. Now you're going to say, oh, but you told me I don't have to share it, right? Everyone here in the call has at one point opened a PDF on their browser, right? And you know that even if you're opening the most sensitive PDF in the world that has got all of your medical data on it and your bank statements and everything, you know that that is not being published on the internet somewhere. We use your browser. This is the when you're showing a PDF, you use the space in your browser and the software around your browser to open something, right? So there's a space there that we can work in. And this is where we call the model to sit. It's nothing leaves your computer ever. It sits in your browser. So the model comes there, and all you have to do now is you have to align your data to make sure that it looks like what we expect it to look like, right? So this isn't, and now if we are interested, we can actually upload our own model on here, right? Which is the one that we've just published. So we haven't finished it yet, but for instance, Elsa can do it, and we can do it for ours. Other people who are building AI models, we can help you also put it on here. So you just put it on the back end. We can show you how to do that. Then it's open to people and people can use it and test it, right? And so here you make sure that your data looks the same, right? And all you do is you drag and drop. Now it might feel, we got some bad feedback from people going, oh, but it feels like I'm giving my data away, but you're not. It's just showing where the path is. So we do have to figure out how to like communicate better that, you know, you're not dragging and dropping your data onto the internet. It's not being uploaded in any way. It's just the model now knows where to go. So we have to, if we're interested in your feedback and how we can communicate that more visually, but still haven't figured it out. But this just shows the model when it's inside your browser, where your data is, maybe on your computer or on a server, it doesn't matter. And then the model can learn from your data, train, and the only thing that gets sent back is this a gradient. Now, this is not something new, right? This is exactly how your predictive text on your phone works as well. No data is left, but it trains a bigger model somewhere in the cloud. But your model gets better itself as well, personalizing to yourself. So now that you've just dragged and dropped your data over here, but it's not dragging and dropping your data, it's showing the pathway. All you have to go is next. And now you can choose to train locally, which means nothing leaves at all. And it's just the model that is on your browser, and you train your own model selfishly by yourself, and you're welcome to do that. So you can train it by yourself. You just have to click the start training, and the training will take place. Okay. And then over here, you can decide to train collaboratively. And if we do have several participants online, more or less at the same time, within a day or 2 days or something, because we can train asynchronously, we can actually train models together, right? And so this is working end to end, and all we need is interest from people, and for us to get, for instance, models that we can upload on the back end of this, which you'll see it's an open, you can go to the GitHub. If you are a data scientist on here, you can go there and see exactly how it works. This is 100% open source. We are academia, right? I mean, we're not commercializing stuff. We're not a company or something like that. So it's about like making open source stuff. You can even have your own disco. You can do what you want with it, right? This is 100% open source. And then once you've done this, you can actually go and test the model, do evaluations, save the model, make it yourself, publish it if you want. You can do anything you like. So this is a very concrete way of like how we want to go forward with training models together, and still doing it quickly, so we don't have to wait on 1,000 DTAs that take 5 years to happen, or rely on this kind of old school central database where we have to copy paste data all the time, right? Which is actually not necessary sometimes, right? So that's something that we want to do. And the last thing that I will say is that we also can build a foundation model with this, right? And here we've got like ways to build these foundation models, which are actually really exciting, because we can drag and drop images onto the and I can actually show you right now. We can drag and drop images onto a chatbot. So like, and our chatbot could be something like really dedicated to our settings. So you can imagine over here we've got like oh, did I say something? Oh, sorry, my email is not verified. Sorry about that. But I could go and close that. So that's good. So over here, I've got like, I wanted to show you something where we've got this chatbot that we can also make that can interpret these images, and we can actually have a discussion. And it really builds on what Jacques was saying before about how we can make pedagogical, not only courses, but self-learning, established ways of people to engage with feedback, right? And now imagine if you've got an alternative source where you can kind of throw your image into, just like we would do with ChatGPT, throw your image into ChatGPT and ask it to interpret something. So here we could also have, I'll just type in something like, what is a signification? But this is like just typing it, but we've also got one for that you can drag and drop images. I just don't have an image here, right? Signification of B lines in lung ultrasound, right? And so we can ask questions like this and get answers from various models, right? And then you could imagine if I had an image here, I could just drag and drop it in there. And now you can get feedback on these models. These are various models that are answering, right? We can get any model. It's, again, model agnostic. We're not selling a model, right? We don't care about what model is being used. So over here, you can see I've got Meditron, GPT-4. Meditron is ours, but whatever, DeepSeek, Llama. We can have any kind of model in here. And then we can actually test which one we like best, give our expert feedback about why maybe this one was better, but maybe it like missed something here, and we can add some stuff and we say, well, that's I want to save this and this should be changed in the future. Give granular feedback about why this aligned with guidelines, why it understood the question. If it had logical reasoning, but maybe it wasn't complete because I had to add something in, and the thing that it missed out was actually quite harmless and it wasn't fair to my context, etc. And I can give this critical feedback about why this answer was good or bad, give extra additional stuff here, why this one was maybe bad as well, because it was a worse answer, and give feedback if I wanted to. I can then submit this. I won't, because obviously this is live and I would poison the well. But this is the kind of feedback that you are actually building the model yourself with your expertise. So very important. I'll stop here because I think I've just reached the end of the thing. But this is a very tangible tool to contribute to. And it's a way for you to actually take your own data, because you can have your own authorship. You can have your own fine-tuned model back for your setting. You can have reports to understand which model is best for your setting. If you're trying to compare all the models and say which ones are best, maybe you can see the difference between DeepSeek and GPT-4 for your setting, who's winning, DeepSeek beats GPT-4, which is pretty cool. And all of these things that we can do very tangibly to have, first of all, collaboration on building collaborative trials together on a platform trial architecture with global representation, right? So there isn't a central ego involved in any of this because it is fully horizontal and collaborative. Then we can have collaborative models that you can own personally, personalized to your setting, as well as collaborate to a bigger consortia so that you can ensure that your patients are represented, right? With DISCO and any model. You have a space to go and contribute your model to ensure its utility is maximized if you are a data scientist on the call. And you have a way to take the more foundational models that are these huge models and put them to the test on your data set to ensure that these chatbots, not just the predictive models that we had said before, where I was showing you the ORCROC, but the chatbots understand and have a pedagogical level that is adapted to your expectations as an expert. These are different ways that we collaborate, and I really hope that these concrete things that we can do will allow us to work together in a meaningful way so that we can match the size of the collaboration that is needed to build models that represent our patients. So yeah, thanks. I'll leave it there, and I'm very happy to have your feedback on this and hopefully your collaboration.
Great. Thanks so much for that, Annie, and thanks for your patience. I know we're a little over time. 1 minute from me. If you like what you just saw, which is mind-blowing in terms of having a technology platform to actually build a community of practice, we'll be sending you an email with some instructions for how you can respond to what you just heard. In some cases, you might want one-on-one meetings with the IMCI Plus team. That will be fine. We can organize those. But there'll be a set of instructions for you to engage with these platforms that Annie has just outlined, and a suggestion for how we can come together periodically as a group to strengthen this community of practice. I want to thank everyone who shared their work. This is just the beginning, hopefully, of a much longer, fruitful partnership. and look forward to our collaboration and working very, very closely on this really cutting edge area of global health. So thank you so much, everyone, for sticking with us. As you can see, this is a really exciting area of future work when it can be enabled by these new AI tools. So thank you to the IMCI Plus team. You're awesome, and we look forward to more engagement. Thanks, everyone.
Thank you so much, and thank you, Leith, as well.
My pleasure. Thanks, everyone.
Thank you so much. So wonderful.